I am now very pleased to introduce our next speaker, who is Jenna Leader. Jenna is a physical therapist at Beth Israel Deaconess Medical Center who specializes in pelvic floor physical therapy. And this is another topic of great importance, I think, to many of our patients, but one that we probably don't discuss as often as we should. So I'm very pleased to welcome Jenna Leader to talk to us today about having confidence in your continence.
Hi, everyone. Thank you so much for having me. I'm very excited to give this talk. I hope everyone finds it beneficial. We will be going over a lot of things. So if you have questions, same as always, just send them over to the chat and we will get started. Okay, so my topic is have confidence in your continence. I'm a pelvic floor physical therapist working at Beth Israel. So to start, what is the pelvic floor? So the pelvic floor is a group of muscles. They lie between the two sits bones. So if you're sitting down right now and you rock side to side, you can kind of feel those two bones that you're sitting on. Those are called your ischial tuberosities, or more commonly, we call them your sits bones. And the pelvic floor lies right between those two bones. And then they go from the front of the pubic bone back to the tailbone. There's a variety of different muscles here. Male and female both have a pelvic floor. And these muscles work to contract to maintain continence of both urine and stool. They relax to allow for bladder emptying and bowel emptying. And then they also support the pelvic organs, and then they stabilize the pelvis. Okay, so certain dysfunctions that we can see with the pelvic floor. In terms of urinary dysfunction, I treat a lot of urinary incontinence. This can be either stress or urge incontinence. And we'll talk a little bit more on that. What's the difference between the two? I also see urinary retention or incomplete bladder emptying. This is kind of a sensation where you may go to the bathroom, you try to empty your bladder, and then when you stand up, sometimes people feel like, oh, I don't feel like I fully emptied, or they'll leave and 10 minutes later, they feel like they have to go to the bathroom again. That is something we can also treat in pelvic floor PT. That can kind of go hand in hand with urinary frequency as well, and urgency. So frequency, normal bladder frequency throughout the day is going 5 to 7 times per day, or around every 3 to 4 hours. Anything more than that is considered urgency or frequency. Sometimes I give a little bit of leeway with that. But if you're feeling like your bladder frequency is interrupting your daily activities, or you're nervous to go out in public because you're nervous to use public restrooms because you feel like you always have to go to the bathroom, that is something we can treat in PT. And urgency as well, we'll get more into this on the next slide, but urgency is that feeling of you can't quite make it quick enough to the bathroom, or you're getting home and that key won't go in the door quick enough to get inside to be able to empty the bladder. A lot of that we train with bladder retraining. And then nighttime voiding, waking up in the middle of the night and going to the bathroom. That can be very disruptive towards sleep. So that is definitely something we treat in PT as well. And then bowels, as Dr. Itorino was just talking about, I treat a lot of constipation or incomplete emptying, that sensation where you may go to the bathroom and you feel like you didn't get everything out, or you're sitting and you're straining, like Dr. Itorino was talking about. We work in PT on the mechanics of how you're actually pushing for your bowel movements. And incontinence, we treat that as well, fecal incontinence. Sometimes that kind of goes hand in hand with constipation. If someone's not fully emptying, they may experience what we call is kind of like an overflow incontinence, or it may be just weakness in the pelvic floor. So we will treat that with strengthening. And then stability, as I said on the previous slide, these pelvic floor muscles provide a lot of stability and support for the hip and the pelvis. So weakness has actually been associated with an increase in fall risk. So we do work on strengthening for that as well. So the two different types of incontinence that we see mostly in pelvic floor PT is stress incontinence and urge incontinence. Stress incontinence is any leakage from increased intra-abdominal pressure, such as with coughing, sneezing, laughing. Sometimes I'll even consider kind of a stress incontinence. Sometimes it's more considered functional incontinence with leaking with like sitting to stand as well. And then urge incontinence, as I was alluding to before, is that feeling of not being able to get to the bathroom quick enough, or that feeling of like that key in the door where you can't open the door quick enough and you have leakage. This is a little bit more common in Parkinson's, and that's because there's a muscle that lies around the bladder called the detrusor muscle. And that muscle kind of overly contracts at times that are not appropriate. So lifestyle modifications is always where I start in PT. I always consider myself very lucky whereas I have an hour with my patients the first time I see them, and then our follow-up visits are 45 minutes. So I have a lot of time where I can actually work on different lifestyle modifications, which I find to be the most beneficial for people. Things that we go over is weight loss. That extra pressure from extra weight can put extra pressure down on the bladder and the pelvic floor. Dietary changes is probably what I focus on the most. So decreasing certain bladder irritants, such as alcohol, caffeine, or carbonated beverages. You know, a lot of us now are drinking seltzer waters. They seem to be the big thing now, but the carbonation within the seltzer water is actually a bladder irritant. So even simple educational things like that, maybe some people don't know. And when they're able to sit down with me, we can go over what they're drinking throughout the day and how that may be affecting their bladder habits. The most important thing is to avoid dehydration. This kind of goes hand in hand again with what Dr. Itorino was saying with that constipation. Sometimes people will dehydrate themselves because of their urinary symptoms, but now that is actually making their constipation worse. So we really focus on balancing the right amount of water intake. And this is important too, because proper water intake allows for proper bladder emptying. Sometimes with that sensation of not fully emptying the bladder, a lot of times it's actually because the bladder isn't actually full enough. I always describe the bladder as being a balloon. If that balloon isn't filled to its full capacity, when it's time to empty, the muscle around that detrusor muscle that I was talking about before isn't able to contract as well. So in order for proper bladder emptying, we have to properly fill the bladder as well. And that's where drinking enough water comes into play and is very important. And avoid jicking. So this is something that a lot of us probably do. This is going just in case. This is that feeling of, oh, I'm leaving the house, I'm going to go to the bathroom, or I'm getting somewhere, I'm going to go to the bathroom first. And it's always that kind of thought process of almost planning our bathroom trips. And again, this can kind of lead to that frequency and that urgency, that key in the door. If we go to the bathroom every single time we get home, our bladder and our brain start to become into that habit. So a lot of times what I work with people in my office with is trying to break those habits. So my trick is always, if you're just getting home and you're in the car, stay seated, stay in the car, and try to gain control first before going inside. A lot of times that's with either Kegel contractions, urge suppression, which we'll get into. So that's the big strategy there, and kind of breaking that habit of going all the time in those situations. And then I say, once you get inside, try to sit down on the couch or something and avoid going immediately so you can start to break that cycle. Then for nighttime, I do tell people, you know, maybe try to limit your fluid intake at night, maybe like 2-3 hours before bed. Try to limit fluid intake so you're not waking up consistently throughout the night. And this is always important in terms of bladder irritants as well. You know, again, having maybe a glass of wine with dinner or something like that. If you're someone who's waking up 2 to 3 times at night, sometimes I'll educate people to maybe either do that earlier or to kind of cut back a little bit so that you are able to sleep and get more adequate sleep throughout the night. So this is that bladder retraining. This is what I was alluding to before with that key in the door or just getting home. We use this a lot with urge incontinence. I use a bladder diary. So the first time I see my patients, I have them fill out a 24-hour bladder diary. Sometimes they'll do it over consecutive days until they see me again, so we can get a baseline of where their habits are currently. So say someone is going to the bathroom, I look at it with them, and it seems like almost every hour. My goal as a physical therapist is to say, okay, how can we increase this time in between trips to the bathroom? And I start slowly. I start with just 15 minutes to try to use these urge suppression techniques to try to expand that bladder so the bladder can start stretching. Again, like I was saying before, the bladder stretches and contracts in order for filling and relax and releasing. So if your bladder is filling every hour and then you empty, filling for an hour and then you empty, this is what the bladder starts to think is full, because that's what we've trained it to be full. So I start with just those 15-minute intervals to try to expand the bladder slightly so it can get used to actually filling a little bit more. I use a lot of urgency distraction techniques with my patients as well, and Kegels. So doing a few pelvic floor contractions actually helps to stop that detrusor muscle around the bladder from contracting so much. And then using distraction, thinking of anything other than I've got to go, I've got to go, I've got to go. And then those void intervals, that 15-minute time interval between trips to the bathroom, we slowly will start increasing that throughout the treatment program. This is an example of the bladder diary. So this is that 24-hour period that I will have patients fill out. The first column is just the type and amount of food or fluid intake. My main concern here is really fluid intake. So how much water or how much bladder irritants even are my patients drinking throughout the day? Amount voided, I don't have people necessarily catch with a hat, so ounces. Sometimes they'll just say, was it a small, medium, or large amount, or how many seconds was the urinary stream? And then was the stream maybe even interrupted a little bit? That's very common as well. That's that urinary retention where you'll start to urinate a little bit and then the muscles in the pelvic floor contract. So you can't get the bladder to empty all the way, or they may even start releasing in between. So you have that kind of start and go stream. So those are all the details that can even be filled in there, even underneath the comment section on this. And a normal stream, I usually say, is around an 8 Mississippi count in terms of bladder emptying. So that's kind of a good guideline. So for my patients, I'll say normal is 8 Mississippis. Let's see where you're at in terms of how much you're actually emptying each time you go to the bathroom. And then if there is any leakage, how much was the leakage? Was it a small, medium, or large amount? So small would be just a few drops, medium, maybe a few tablespoons, and then large to the point where you felt like you had to change. Urgency, this is important for retraining for that urinary frequency and urgency. A 1 would be that going just in case, or that jicking, where you didn't really have to go to the bathroom, but you kind of told yourself, well, I may just go because I'm leaving the house, or I just got somewhere, let me just go to the bathroom before I do anything. And a 2 is more that urge where I had to go to the bathroom, but I was able to make it. 3 is where we're kind of doing that dance before actually getting to the bathroom. And then I have patients fill out here in this last column what they were doing with any of that leakage. Was it with a cough? Was it with a sneeze? So is it more of that stress incontinence, or was it maybe even on the way to the bathroom, which would allude to more of that urge incontinence? So this I was talking about a little bit already, but we'll go over this just so everyone knows exactly what I work with or how I do the urge suppression. So my first step for my patients is to stop what you're doing, sit down if you're able to, or stand in place. You know, a big trick that I use on that walking, like a lot of times people say, well, I go for a walk, but then it's once I start getting close to home, I feel like I have to go to the bathroom so bad. So I'll tell people, well, if there's somewhere to sit, try to sit down on a bench that you may know is close to home. If you're in the car, stay seated. That seated position actually helps to support the pelvic floor. So it supports the perineum, which is the area of skin between the pubic bone and the tailbone. So that pressure there actually helps to support the pelvic floor. That's why sitting down is sometimes a little bit more helpful. And then you distract yourself. Think about anything other than I've got to go to the bathroom. A lot of times I give my patients a little bit of a mantra. The whole entire purpose of this presentation is to have confidence in your continence. So I tell people, you know, tell yourself that you have confidence in your ability to control your bladder. So instead of saying, I've got to go, I've got to go, I've got to go, think instead, I'm in control of my bladder. I'm in control of my bladder. My bladder does not control me. And then the second step is to perform light Kegel contractions. This can just be quick flicks. So those are just lightly tightening the pelvic floor and then releasing. And we'll get into how you actually do a Kegel contraction, because that's the biggest thing I get, or question I get with my patients is they'll say, yeah, I've heard of Kegels. I think I'm doing them right, but I have no idea if I actually am. So that's something I work a lot with awareness. And then distraction, again, thinking of anything other than I've got to go, I've got to go, I've got to go. And then relax. That urge incontinence where you're maybe are leaking on the way to the bathroom, a lot of times is because we're too nervous or we're rushing. Our nervous system now is in overdrive and we're just trying to rush to that bathroom, and that can actually cause leakage. If you relax, take some deep breaths, it calms that detrusor muscle around the bladder down, so you're not getting as strong of contractions. And you want to slowly walk to the bathroom to try to control any leaking that you may have on the way to the bathroom. Or like I was saying before, the ultimate goal is to actually be able to wait. I start again with just those 15-minute intervals to start to retrain the bladder, and then you can slowly start progressing that over time. Kegels. So how do I train Kegels in office? I use these muscle contractions for both stress and urge incontinence. The goal, of course, is to help strengthen and support the pelvic floor and the muscles around the urethra. So biofeedback, is, as Dr. Itorino was talking about, can be used. It's a very helpful training tool. So you can see this screen here down at the bottom with the biofeedback. You can see this would be what we call as an endurance hold. So you can see the muscle contraction going up, going across, and then releasing down. So this is a very good visual feedback for patients. You can see the relaxation here. This here would be an internal sensor. This can go vaginally. The silver here that you can see slightly is the actual probe part that picks up on the pelvic floor muscle contraction. The sensors over here, these are external electrodes. These would just go right on the perineum. So these are a little bit easier for people to use because they're more comfortable rather than using the internal sensor. So the two types of Kegels that I train are quick contractions and endurance holds. So a quick contraction is used more for stress incontinence. This is that increase in pressure with that coughing or sneezing that can cause leakage. So the quick contraction, I have my patients do a quick squeeze, a release, a quick squeeze, and then a release. This can also be used for that urge suppression, like I was saying before, doing those quick flicks. Versus an endurance hold, which is on that biofeedback screen that you saw earlier, that's more used for increasing your overall strength. So sitting down and doing a hold of the pelvic floor rather than a quick squeeze. Those are sometimes a little bit more difficult for people to do. Sometimes they have a hard time feeling that endurance hold. They'll be able to hold it for a little bit and then they may drop that contraction. So a lot of times I'll tell people to try to work on increasing your endurance over time. Start with just a 5-second hold and then slowly maybe progress to a 10-second hold, which is the ultimate goal. So the correct contraction. So to feel these muscles, you want to think about stopping the flow of urine or stopping the escape of gas. Because these muscles go from the pubic bone back to the tailbone, you want to feel these muscles contracting both in the front as well as the back. So when you're squeezing and holding in urine, you're kind of feeling that more in the front. And when you're stopping the flow of gas or stopping the escape of gas, you're feeling it more in the back. So you should feel the anus tightening as well as either the vagina or the testicles lifting. You never want to hold your breath. That's kind of the tricky thing with the endurance hold. A lot of times I find if I tell someone just to even hold a pelvic floor contraction, I find a lot of times they hear that word hold and they immediately start holding their breath. So sometimes instead of holds, I'll say, try to squeeze that muscle on and then re-squeeze it to maintain the endurance. You never want to hold your breath because when you do, that breath holding actually pushes down on the pelvic floor rather than lifting it up. Our whole entire goal here is to be able to do a contraction, which is lifting of the pelvic floor. When you hold your breath, your diaphragm actually pushes down on the pelvic floor and causes these muscles to release down rather than lifting up. Other common substitutions are gluteal squeezes or butt squeezes, abdominal sucking in, or even inner thigh tightening. So you want to kind of think about the substitutions as the muscles that may be activating when you have to go to the bathroom really bad. We kind of tend to squeeze our glutes, we cross our legs, we pull in our stomach, hold our breath. Those are the things that you want to avoid when you're actually trying to strengthen the pelvic floor. So to move on to pelvic floor and bowels, this is something that Dr. Irino was talking about. We'll get into a little bit more detail now of how we actually treat this conservatively with the pelvic floor and with pelvic floor PT. So we consider pelvic floor PT constipation, outlet constipation. That's when you may feel like you don't fully get everything out, or you feel like the stool is right there, but you can't pass it. You can't get it all the way out. Or you're straining for your bowel movements. Again, that straining can cause weakness in the pelvic floor. So we want to really address both things. This is why we focus on kind of the whole big picture. Like I was saying with the how much water you're drinking throughout the day, that can cause your constipation to get worse. Well, with constipation, if you're straining for a really long time to try to have these bowel movements, you're pushing down on the pelvic floor and you're making these muscles a little bit more weak. So that's always very important to think about as well. Fecal incontinence, that can be kind of here where I have the fecal incontinence and the overflow incontinence. It can be two different things. It can be just pure weakness with the pelvic floor, or it could be more of that difficulty with actually coordinating these muscles. So are you getting the incontinence because you're not able to empty all the way during your bowel movements? So now that stool is kind of coming around, the more constipated stool that's maybe left over. So a big thing that I do here, again, is lifestyle modifications. Thinking about the history. What is your history like with your bowel movements? Are you feeling that sensation of not being able to fully empty? Or do you feel like you get a little bit out and then you may have leakage afterwards? Thinking about those type of things. So really sitting down together and talking about what your symptoms are with your bowel movements. And then we'll go over again the lifestyle modifications, increasing the water intake. Like I said before, never limit your water due to your urinary symptoms. Tracking that dietary fiber, again, as Dr. Itorino was saying, sometimes people get more gassy with the more fiber they eat, but sometimes that's also, like she was saying, because you're just constipated. If you're not getting all that stool out, all that good fiber is just left over, and it's going to cause a lot of that gas. So the biggest thing with treating gas and bloating is getting your bowels to move properly. And if you're thinking about, you know, the Miralax and that type of thing that Dr. Arino was talking about, that's addressing the motility aspect of constipation. Now, if you're addressing the motility, but now the pelvic floor is at the last step and it's at the exit, if you're not able to expel and get all the stool out, that's where it can be difficult in terms of still having constipation despite being on these motility medications. So a lot of times I'll work with GIs to address both the motility side, that's what they'll do, and then I address the pelvic floor, being able to actually get the stool out. So I always describe it as a traffic jam. You have to kind of get that first car moving in order for the rest of the cars behind it to be able to flow through. So we've actually found if you can address the pelvic floor issues at the exit for constipation, motility will actually speed up and increase because now the stool can actually move through and get out. And then regular physical activity is always important. Again, that's going to help with the motility, getting up, trying to do a little bit of walking, doing a little bit of stretching, that type of thing. A lot of times I work with just a little bit of a stretching routine with my patients as well. And then again, like Dr. Reno was saying, maximizing that morning routine, maximizing that reflex, eating something good for breakfast, having those 2 kiwis. I always tell my patients to try to have kiwis. That's always something that is very helpful. And then trying maybe 20, 30 minutes after eating to actually have a bowel movement. A lot of times, you know, people who become more constipated, we're just not in the kind of the practice of trying to have a bowel movement regularly. So we don't even think about it in the mornings. It doesn't even become like one of our thoughts. We just notice as the day goes on, we're feeling really bloated and really uncomfortable. So I really try to reverse that. I try to make that morning routine more of an actual habit more than anything. So getting up, drinking a warm glass of water, walking around, having something good for breakfast, and then going into the bathroom and just seeing if there is anything there to actually produce a bowel movement. And that's where we talk about what is the proper way to push in the bathroom, because I don't want my patients just going in and straining. So I'll get to that in a few slides of how do I actually retrain for that proper pushing with that pelvic floor relaxation. And then in terms of if there is just that true weakness in the pelvic floor, we may work on just increasing your pelvic floor strength. And that's more for that fecal incontinence. So treatments, training that proper relaxation while bearing down to help with that complete emptying and then to reduce that overflow incontinence. This here is a Bristol stool chart. This I use very often, sitting down with my patients, figuring out what is the consistency of their stool. Is it hard, pebble-like? Is it a little bit harder and more formed? 3 and 4 here, this is more ideal, where the stool is soft and formed, easy to empty. 5, 6, and 7 is where the stool is a little bit more loose. So this is always important as well, just to get that baseline. Ideally, we want to bulk the stool if we're down here with this 5, 6, 7 to get to the 3 or 4. And then the 1 and 2, where the stool is more hard, pebble-like, that's more constipation. That's increasing the water. That's working on actually being able to get a more regular bowel movement so the stool isn't sitting there and just getting dry. And then again, avoiding the straining. You don't want to weaken that pelvic floor. We want a good pelvic floor function overall in terms of proper strength and proper relaxation. And then lifestyle modifications, as I said before, working with the water, working with the fiber, and then working with a GI in terms of what are appropriate motility medications in terms of stool softeners or laxatives as well. So proper bearing down, this is probably the area of my treatments that we focus the most on with pelvic floor in terms of constipation. It can be very difficult to relearn. And a lot of times I tell my patients, you have to be patient with relearning these strategies of proper pushing, because it may be something that your body has been so used to and you may have been doing for years now in terms of pushing the improper way. So relaxing and taking your time. That's probably the most important thing. Really giving yourself time in the bathroom, not time to be just sitting there and straining the whole time, but even time to digest in the morning. You know, sometimes I tell people if you have a busy work day where you're up in the morning, then you have to leave really quickly, you're not taking advantage of that reflex. So maybe waking up a little bit earlier, giving yourself 20, 30 minutes after having breakfast to be able to relax and let your GI system start working. And when it comes to the actual pushing, I use abdominal pushing. So using your stomach to actually do the push, and your stomach should be pushing out and down. So the downward pressure is that intrarectal pressure Dr. Itorino was talking about. So that's just being able to push stool down. And then the pelvic floor relaxation is, again, that muscle that they were talking about here that slings around the rectum called the puborectalis. And this here is the external anal sphincter. So these are the pelvic floor muscles. These muscles we have control over. So this is what we use with the biofeedback. Again, those sensors can either go externally or internally, and we'll use the biofeedback so you can get a visual on a computer screen of knowing if you're truly squeezing or releasing during your bowel movement. Obviously, the goal here is to relax. And then we see here this angle, this blue. So this is called the puborectal angle. And with sitting, we have a little bit of a smaller angle. This is where you may have heard of squatty potties or using something that's going to elevate your knees above your hips. That's to actually increase this angle, which allows for that pelvic floor muscle, that puborectalis muscle, to relax so stool can exit easier. So again, the goal is to get that intrarectal pressure to push down, and then with that pelvic floor relaxation. The key is to breathe properly, which we go over a lot in our treatments, and then avoiding the straining. So with that, again, so going back to the biofeedback for this. So we use, again, those either external sensors or an internal sensor. And you're sitting, and when you're pushing, you'll see on a computer screen what's happening with the pelvic floor. Because this is all easy to kind of conceptualize and understand. Yes, these muscles have to relax, but how do we actually retrain that? How do we actually achieve that goal? And the biofeedback is what we use. So that was the research that Dr. Itorino was showing of treating motility, but then also doing it in combination with the biofeedback. That's where PT comes into play. And if you recall in those previous slides where I showed those two different sensors, the two sensors that are red and one green, those are the external sensors that we'll use on the pelvic floor, or you can use an internal sensor. Sometimes the external sensors are more comfortable to sit on, because that's our whole goal here, is to retrain the proper pushing so people are sitting. But the internal sensor is helpful for a tactile cue of being able to feel your muscles relaxing around that internal sensor. Now, in addition to the biofeedback, our goal is to see those muscles relax. But in addition to that, I'll actually do internal rectal tactile cues as well. And that's helpful too, because the biofeedback is just showing us if these muscles are squeezing or relaxing when you're simulating your push. Whereas my internal exam or internal cues will actually be able to feel how well are you pushing down in addition to relaxing. So the take home from all of this is that we need proper pelvic floor muscle control, both when it comes to proper strength and proper relaxation. Everyone has a pelvic floor. I know a lot of times we think of Kegels and postpartum and you know, women with their pelvic floor issues. I would say that in my clinic, I probably see a pretty even split of men and women in terms of their pelvic floor dysfunction. So it's important to kind of discuss these issues with your providers. You know, if you're having issues with urinary symptoms, don't be afraid to talk about it. You know, same thing with the bowels. If you're having issues there, don't be afraid to talk about it. Now, hopefully, you know, pelvic floor PT is an option, something that we can help with. Because a lot of this is a big impact on quality of life in terms of urinary urgency, urinary frequency, not feeling that you can leave the house as easily because you're not able to use public restrooms, or you don't want to use public restrooms. So quality of life stuff is really impacted with pelvic floor dysfunction, and I encourage everyone to get the help that they need. So remembering that proper strength is needed to maintain continence, and proper relaxation is needed to allow for proper emptying. So have confidence in your continence. Be aware of your pelvic floor. Practice those Kegels to just strengthen the muscles. So again, a lot of times I'll start with just that 3 to 5 second hold, resting for 5 seconds, repeating that maybe 5 times, and then doing that 3 times per day. So you're doing these Kegels a few times throughout the day. Once you get better at these Kegels and that holding, you can increase to 5 to 10 second holds with a 5 second rest period. Same idea, repeat 10 times now though, because now you're increasing the repetition. So working on progressing that exercise. And then same thing, doing that 3 times per day. And the NAC, this is really helpful for stress incontinence. So the NAC is helpful. What it is a pelvic floor contraction prior to increased pressure. So if you're coughing or sneezing and that's when you're having your leakage, I tell people squeeze those muscles in the pelvic floor before that increased pressure. Usually we can feel when a cough is coming on or a sneeze is coming on, we get that little bit of a tickle in the nose. So squeeze the pelvic floor first before that increased pressure. And then of course, now you know some good bladder habits. Use those urge suppression strategies for retraining. drinking enough water, decrease irritants, and then avoiding that going just in case. And then when it comes to your bowels, maximize your bowel movements, maximize your morning routine, working on the dietary fiber and the water, and then trying to work on that positioning. Again, using a step stool maybe to elevate your knees above your hips, using your stomach for the pushing, making sure you're breathing, and trying to feel for that pelvic floor relaxation when you're actually having your bowel movement. And that is all I have. Thank you so much for listening.